Prior to discussing other elements of the advanced life support algorithm, it's necessary for us to review the key points of high quality CPR. If we do poor quality CPR and rush into giving drugs or advanced airways, our patient will die every time. It cannot be overemphasized how important it is to do these skills correctly. And as advanced life support providers, our first job when walking into a room with an active code going on is to ensure that CPR is optimal. A couple of important points to consider on the screen here. We have been performing real CPR on real people in hospital settings for 70 plus years. And when you do real things to real people, you get add on studies like you wouldn't believe. There have been tens of thousands of studies on both basic and advanced life support. What works, what didn't work quite so well, what gives us a slightly higher chance of survival. And when you look at all of these studies, we come down with just a few things that we know for a fact increases your patient's possible chance of survival. One, we know for sure if you find somebody laying down and you decide to push on their chest because their heart has stopped, we know for them to have a possible chance of survival, you must push fast on that chest. The current guideline says 100 to 120 beats per minute. Speeds slower than that, say 80 beats a minute or less, they essentially die every time. And speeds too fast also lead to poor survival rates because you're sacrificing other things further on this list. 110 seems to be about best. Two, we know for them to have a possible chance of survival, you have to push deep on that chest. And the guideline says 1/3 the anterior posterior diameter of the chest. But no one knows what that really means in the heat of the moment when you're doing CPR. So another way to remember this is at least 5 centimeters deep. Now, at least is a key word. About 5 centimeters deep is wrong. And studies show that in the vast majority of codes, compressors aren't pushing nearly deep enough. Our goal is to push blood out of the ventricles and up to the brain and the vital organs. Three, we want to allow complete chest recoil on the upstroke. Recoil creates a vacuum in the chest that actively pulls blood in from the venous system and primes the ventricles for the next pushdown. Studies show that leaning on the chest even 1 to 2 millimeters reduces survival rates because there's less blood to flow out on the downstroke. So essentially, this patient's chest right now is just like a giant bellows. But instead of blowing air into a fire, I'm blowing blood up to the brain. And we know for a bellows to function the most efficiently, I have to push it down all the way and squeeze as much air as I can out of a bellows. The same applies here. We also know for a bellows to function the most efficiently, I need to pull it back up all the way and let it fill back up. Same applies to pushing on the chest and allowing complete chest recoil. 4, we want to limit interruptions to CPR. Interruptions in CPR unequivocally lead to poor survival rates. Interruptions reduce our chance of shock success. Ultimately, interruptions kill brain cells. We want to keep all interruptions in CPR to less than 5 seconds. And the reason for this rule, as much as anything else, is to remind us to keep our priorities to doing the simple things well. If you're ever in a situation where you don't know what to do next, you should be on the chest pushing. As you can see here, when we start pushing on the chest, the blood doesn't instantly go to the brain and perfuse the vital organs. You kind of have to prime a pump. So, although you're off the chest for 5 seconds, it may be 10, for instance, before the brain gets circulation again. And that's starting to be quite a long time. This also correlates directly to coronary perfusion pressure, or CPP. A decent coronary perfusion pressure is required to get enough oxygenation to the heart to have potential for shock success. 5, we want to avoid hyperventilating this patient. How much oxygen do we want to give the patient? Well, just enough to see visible chest rise, and that's it. Don't put more in because it makes you feel better. This equates to about half a bag squeeze for an adult. Now, there are a lot of dangers of hyperventilation, And first and foremost is the fact that hyperventilating on a patient increases the intrathoracic pressure in the chest cavity. What that does is that reduces venous return to the heart on the upstroke. Therefore, it reduces blood flow out on the downstroke and directly can lead to the patient's demise. Now, hyperventilation also can lead to cerebral vasoconstriction, and that can lead to further cerebral ischemia. And last, but certainly not least, hyperventilation pushes excessive air into the esophagus, leading into the stomach and gastric inflation. This can increase the chance of passive regurgitation, or if you achieve return to spontaneous circulation, active vomiting and aspiration, which is a leading cause of death in the ICU after the event. Now, ultimately, everything we've talked about so far is a time buyer. CPR does not save lives. There's just very limited evidence that CPR only saves maybe 3%, usually drowning victims. CPR provides us a little blood flow to the brain and the vital organs. Early defibrillation is ultimately a lifesaver, and then when that arrives, that is our priority. But defibrillation will not be successful without high quality CPR. And that's it. When you combine everything we've just discussed and the combination of early defibrillation, these are the things that we know for a fact increase your patient's possible chance of survival to hospital discharge. It's not about the drugs, it's not about the advanced airways, it's literally about doing the basics well.